charge unnecessarily. As simple as that. You just ask them, give us fine sections in a CD, in a DVD, that's it. Don't tell them what you are going to do with that. You know, once I told Dr. Sethi, we had a lot of discussion on this. So he went back Singapore and asked for the 0.5 mm section for the sinuses. You know, their CT scan is so costly. They calculate by number of slices. When I got the CT scan done in Indian rupees, that CT scan to the patient cost almost more than 1.5 lakh rupees. They calculate in terms of slices, number of slices.
They will learn.
And you know, there is a reason to it. All CT machines, you know, they take insurance. All radiologists take insurance.
Yes.
And that insurance is based on number of slices.
No need to do surgery.
Accordingly, they charge according to the number of slices. More finer the section you ask, more they will charge. See now the frontal sinus crystal clear. This
Yes, sir.
patient had a frontobular cell. We opened the frontal sinus with the same ease. Went underneath the beak. See the beak now? You should be able to identify this beak. See this beak?
Yes, sir.
See the axilla. Anybody can identify the axilla. See this axilla? Go underneath the axilla, see the beak, follow the beak where it ends in the frontal. See how the beak is ending into frontal. Can you see?
Yes,
This
sir.
is God's given natural anatomy. I am not doing anything to it. We are just utilizing this information, exploiting this anatomy, which is almost always fixed. You know,
Yes.
a lot of people explain the frontal sinuses in terms of this block concept, this block concept. You have to identify this number of cells, that number of cells. All those cells are never constant. Utilize the landmark, first of all, which itself is reliable. And there cannot be any other landmark in this region which is more reliable than the beak. Okay? So always consider beak as one of the best landmarks, I tell you. Anybody has any doubts about the frontal sinus? That is maxillary. See this maxillary with the 70. That is your lamina. Above the maxilla is the orbit. The medial wall is lamina. And along the lamina, between lamina, beak, and the turbinate, go anteriorly. There is the frontal sinus. And this is almost always a fixed anatomy.
Excuse me,
Okay?
sir. Excuse me, sir.
Yes, please.
Sir, can we see the picture outside this endoscopic picture? The position of the patient and your instruments.
What I will do in the next case,
Yeah.
we'll put up the external camera together.
Yeah.
Okay?
Thank you. Thank you.
We want to see ergonomic position.
Yes, yes. So anybody, any doubts in the frontal now?
Excuse me, sir, I had a question that you're using this 120 angled one of the debrider, but if you don't have access to that, what can we use to achieve the same result that you have got?
See, people have done a lot of things. Cut one point. This is direct method because the frontal sinus is so strategically located anterosuperiorly, you know. And to reach out under vision, 70 is the answer. Ideal. Now, if you're saying there is no 70, then you have to deal with this beak. The obstacle, why we use 70? This is the obstacle. The beak is the obstacle. Tomorrow I'll show one or two draft cases where the beak is the obstacle and we drilled away the beak. Now, in situations like this where you need not to drill the beak with no 70 degree, what you need to do, people are doing a lot of things. People are making the flap here. People are, you know, taking away the part of the beak here. People are making window like Caroline window or something. There's so many, ways people have made, but all those are, nothing can be as direct as 70 degrees. That now,
So we have
now,
70 scope, but I'm talking about this debrider wand angle. If you don't, we have 70, but we
yeah,
don't
you
have
can
this.
have 120 debrider. If you have debrider, why don't you have the 120 blade also?
They have not provided.
Yes, you can have. This is really useful for frontal
Okay,
and
but if it's not there, then what other instrument can we use?
all angle instrument, but they make your life so difficult. See now the skull base behind.
Sir, can you show us the anti-lift model in this?
Yes,
Side.
yes. See this. Keep skeletonizing the lamina for your orientation. This is the best landmark. See the lamina. Always the best landmark for this region. Anti-ethmoidal runs along the skull base. Don't terrify yourself once you are doing. See, this is anteriorly, this is deep in the skull base, deep there. Right into the bone of the skull base, the anti-ethmoidal traverses. Okay? So don't terrify.
Okay, sir.
Flush the skull base.
Sir, have you counted how many cells are there each side?
Why to count? Can you see the vessel there?
Yes, sir.
See, this is the skull base. The vessels run along the skull base. Can you see very clear? Hello?
Yes, sir. Yes.
See, everything has to be mucosal. Now, about counting the cells, the important thing is not to leave any cell unopened. See my limits flushed. Can you see?
Yes, sir.
Along the lamina, all cells flushed. Along the turbinate, see this? Ostium.
Yes, sir. Yes, sir.
Now, staying anterior to the sphenoid ostium, finish your post-ethmoidectomy. See this? Simplest way. Keep the sphenoid ostium in view in 1 minute's time. This is now fast endoscopic sinus surgery. Different FESS. See now?
Yes, sir.
Retrograde, flushing the. See this? Another way of doing the same thing. See now? Everything done?
Yes, sir.